is Karen Kubian, and I am a patient navigator at the Breast Cancer Resource Center in Austin, Texas. The Austin medical community is working hard to ensure the safety of patients and staff, as well as prepare for the expected increase in critical care needs for those that are will be maybe diagnosed with COVID-19. Because of this, there have been a lot of changes in treatment and surgical plans for those diagnosed with cancer. So the Breast Cancer Resource Center has asked some of the medical professional partners in our community to shed some light on the cancer care decision-making process during this time of dealing with the COVID-19 pandemic. Today, I'm grateful to have Dr. Julie Sprunt, who is a breast surgeon. Dr. Sprunt and her partners at Texas Breast Specialists are the only fellowship-trained breast specialists and breast surgeons in Austin. Dr. Sprunt specializes in breast surgery and treats all breast conditions from benign breast disease to malignant. She completed a breast surgical oncology fellowship at the University of Southern California, where she learned unique oncoplastic techniques to treat breast disease. She is board certified by the American Board of Surgery. Dr. Sprunt, thank you so much for joining me today.
Thanks, Karen, for having us and setting up these useful information tools so that we can hopefully distribute and disseminate as widely as we possibly can how we are all thoughtfully managing our patients with breast cancer during this time.
Well, thank you, and we appreciate all of your efforts and giving us your time today. So to jump into some questions, so we're hearing in our community that so-called non-essential surgeries are being postponed or canceled. I think under normal circumstances, we would certainly consider breast cancer surgery to be essential. But can you maybe help explain why even some lumpectomies and mastectomies are being considered right now non-essential and being postponed?
Certainly. So the three big issues as we look at taking patients to the operating room right now during COVID is severalfold. Number one, we are better understanding that there are a large number of asymptomatic carriers who may be carrying coronavirus. And if we take a patient who is an asymptomatic carrier to the operating room and then intubate that patient, there is a significant viral load that is exposed to our healthcare workers. And so that is one of the concerns about taking patients to the operating room at this time. The other concern is that when we operate, we are utilizing protective equipment, and that protective equipment right now is under a severe shortage. And the equipment we are using today may affect the exposure risks to our colleagues, over the next 6 weeks to several months as this plays out. So those are the real two considerations when we think of actually taking somebody to the operating room. And that is why all of our societies, the American Society of Breast Surgeons, the Society of Surgical Oncology, the American College of Surgeons, as well as the governor, our local state authorities are looking at all surgeries, saying if we can safely delay as many of these surgeries as we can, then that will save equipment that we are going to desperately need. It will limit, hopefully, exposures to our colleagues and our healthcare workers. And the only good thing about our patients with breast cancer during this time is that many of them have strongly hormone receptor positive cancers, and that allows us to safely put them on pills and be able to safely delay surgery. So to your point, we all argue that the treatment of breast cancer is essential, period. Fortunately, we can provide good, safe treatment and safely keep some of our patients out of the operating room. But in all of the guidelines that have been put forth, we are still operating on some women with breast cancer because we don't think we have a safe non-operative management. But many of our patients, we do have a safe non-operative management during this time. And it's important that we utilize those safe treatment options. The other thing that we still are trying to continue to understand is, by operating on our patients and bringing them out of their homes, we are putting them at exposure to coronavirus as well. And so that's the other thing that we are just trying to thoughtfully weigh as we try to ensure that we keep as many of our patients safe during this time.
Great. So that certainly makes sense. I think one of the fears for those who are having these surgeries postponed, even though understanding that certainly you're saying they are being treated, just not maybe in the order that they were before. But you know, the perception sometimes among patients, especially those new to the cancer world, are, well, if they're not taking it out, if they're not, you know, if they're not removing it surgically, then it's giving it the opportunity to grow and spread. What do you say to those patients?
That they're not alone, because we've been utilizing neoadjuvant treatment strategies in breast cancer for a while. And in everybody who is originally diagnosed with breast cancer, they want surgery a week before they found out they had breast cancer. And that's completely understandable. Fortunately, over the past 10 to 20 years even, we have understood that many women's breast cancers are best treated by giving either chemotherapy before surgery or even by using a neoadjuvant endocrine strategy before surgery. And so many of our patients still that I'm seeing, I have to have that exact conversation. Listen, you need chemotherapy before surgery. And the only silver lining to this is I would have been telling you this 2 years ago, independent of the current coronavirus situation. So please realize there are a large number of patients who truly do benefit from a preoperative approach. And it's a lot to ask anybody to trust us to say, listen, you don't need your breast cancer out right now. You need to take a pill. You need to take these drugs. And fortunately, we have a lot of good data showing why that is the best approach in many women's breast cancer treatment strategies.
That's great. And then for those patients, how are they still able to be monitored to ensure that things are stable, or hopefully even, you know, by using endocrine therapy or other neoadjuvant therapies, even improving before their surgery can be scheduled?
That's it. So my partners at Texas Breast Specialists and I are all making sure that we have some sort of a thoughtful follow-up strategy. What everyone needs to realize, and this is still something I'm struggling with as we all are, this is an evolving situation and it changes daily. And our understanding of it and our understanding of local resources also changes daily. And so that's something that we are all trying to make sure we keep as updated as we possibly can so that we can update our patients. Most of us are having patients come in, you know, within 3 months of starting them on a neoadjuvant strategy to do either an exam or an ultrasound, get a mammogram if that's how their disease best shows up, to ensure that things look about the same to us. And in what cadence we're choosing to do that as we try to, again, limit our own patients' exposure to coronavirus is going to shift some with time. But when you look at the trials of a neoadjuvant endocrine approach, most patients will be on a neoadjuvant endocrine strategy for up to even as long as a year. And we've shown that that is safe. Now, with a neoadjuvant endocrine approach, the response to treatment, meaning the likelihood that your cancer is going to actually get smaller in size, takes a little bit longer. So generally we don't see a reduction in size until about 6 months if you look at the literature. And so that's where we all have to understand that some women we are putting on neoadjuvant endocrine therapy to safely keep them out of the operating room and temporize their treatment. And then other women we're putting it on so that we actually hopefully can reduce the size of their cancer, and because that has important surgical implications at times. So in women whom we are trying to see, you know, a reduction in size of that tumor, we may actually use a longer endocrine strategy in their treatment.
Okay, great. And what are some other things that they can do besides taking their medication and checking in with you? What are some other things they can do to help take care of themselves in the meantime?
I think self-breast exams during this time can be quite helpful. So if you were diagnosed with a breast cancer that nobody could ever see or feel, continue to examine your breast and say, okay, I still don't feel a mass in my breast. And that's actually a really helpful thing that women can do in a way that you can engage in your treatment. If you start to feel like you now can feel a mass when you otherwise couldn't have before, or if you have a mass that you can feel and you feel that that's getting bigger, then that's something that you need to notify one of your surgeons or doctors about so that we can bring you back into the office and do an exam and do an ultrasound. And we can do that during this time. It's just important to know that many women their disease is going to be stable and possibly even get smaller over this period of time. And we are trying to safely keep you out of our offices so that we minimize your exposure and, frankly, our own exposure, so that we can keep doing surgeries and taking care of women as they are just getting diagnosed during this hard time, and in women who we don't think we have any safe options other than doing surgery for their breast cancer during this time.
Gotcha. Okay, great. And so for those patients who are having surgery, do they need to do anything differently post-surgery? What are you kind of advising them in terms of being at home, recovering? Do they need to isolate from other family members? What are some of the tips and concerns maybe that are different now in the dealing with COVID-19 than they were before?
Sure. So in most of my patients leading up to surgery, I am actually calling them and really trying to encourage limiting their exposure. Again, my biggest concern and the decisions that weigh on us very heavily as providers is to, number one, do the best we can for our patients, but number two, make sure that the operative team that is gracious enough to help us take care of our patients, that they stay safe. And so we really want to prevent a situation where we do intubate somebody that is either an asymptomatic carrier or is having very subtle symptoms of coronavirus. And so again, from a preoperative standpoint, to really try to limit your exposure to people, and also to be honest about your symptoms if you do start developing symptoms. That is not something that we want anybody to hide, because again, we could still probably take just as good of care of those people, but we need to know about it so that we can appropriately protect ourselves. As far as after surgery, fortunately, after surgery, a lot of women are, prepared and planning to hunker down at home as they recover. And I think hunkering down at home with the people that you know and love is exactly what we all should be doing, and exactly what I expect my patients to do after surgery. Now, do I want them going to the grocery store? No, that is something that you need to send others to do for you. But I probably would have told you that is the case for 2 weeks after surgery 6 months ago. So, I mean, most of the things in a post-operative setting are going to be pretty similar. The only other big difference that I'm doing, and most of my partners at Texas Breast Specialists are doing when we can, is setting up telehealth appointments to do post-operative visits, especially for our patients that don't have drains, that don't necessarily need to come in the office. And that's actually been working really well. I had an excellent post-op appointment with one of my patients yesterday, and she was the best and said she'd been trying on all different clothes so that I could best do an exam. And the useful tip she had, and it was actually really helpful, she wore a big shawl almost. So she was completely covered. But then when it came to a breast exam, it was so easy for her to show me her incisions. And that's really all we need to see. As long as the incisions look okay, then we're able to upload pathology documents. We can email that to our patients. So unfortunately, we are adjusting to the new normal.
Great. Okay. And then, so when things start to let up at some point, and obviously we don't know when that's going to be, because as you said, it's a constantly changing environment right now. But how can breast cancer patients be sure that they're can get their surgery scheduled as soon as possible? What kind of things do they need to do in terms of working with you on an ongoing basis to be sure that their surgery is done when the time comes?
That's a great question. And that is something that we are already talking to hospitals about, as we all have appropriately tried to delay anybody's surgery when we think it's safe. We also are telling those hospitals, listen, this means that as these women are gracious enough to, employ this safe treatment strategy, we need to make sure that they are front of the line when these operating rooms do open back up and are safe for us to use. And that's something that we are already having those conversations with all of the hospitals and surgery centers, to have a ramp back up strategy so that our patients with cancer are at the first of that line. And so far, our hospital partners and surgery center partners have been very understanding of that and are starting to set plans in place so that we can do as much surgery as possible in our patients with breast cancer when we think it's appropriate. And again, realize that's not always going to be, not everybody's, as soon as they say open up the ORs, is actually going to need surgery. Some women are, being put on endocrine therapy with different treatment strategies. And also in women who are starting chemotherapy now, their surgery, usually won't take place for another about 5 to 6 months from now. So fortunately, we're trying to look at all of that patient flow process and make sure that we are prepared to do everybody's surgery at the most appropriate time when we can say that's the safest option.
Great. Dr. Sprunt, this has been tremendously helpful. Thank you so much for sharing your thoughts and your time today. And thanks for all you do for breast cancer patients in Central Texas. We are so grateful.
No, absolutely. Listen, I am so grateful for you all doing this. And please know, to all of our patients, these are not decisions that we take lightly. And we are talking among all of our surgeon partners at Texas Breast Specialists about every individual case and how we ought to best treat it during this time. And I cannot thank you all enough for your trust in us to help manage you all's disease as we go through this.
Thank you. And please take good care of yourself.
Everyone stay safe.
Yes. Thank you.